cut off. Level 8 years. Diabetes mellitus complicating pregnancy. I'm Dr. SARITHA, Professor of Obstetrics and Gynecology at Maladi Medical College. Today I'll be speaking about diabetes complicating pregnancy. Diabetes happens to be one of the commonest complications which is seen in a pregnant woman. When you have about 17 to 18% of the urban population and about 10 to 11% of the rural population with being diagnosed with the diabetes, it is seen in a pregnant woman, and you can divide this diabetes complicating pregnancy into two types. One is the gestational diabetes, which is the first recognition during the pregnancy after 20 weeks of gestation, and the pre-gestational diabetes, which is before the woman becomes pregnant. The diabetes is existing in women. That it can be either a type 1 diabetes or a type 2 diabetes. Gestational diabetes is the diabetes which is first recognized during pregnancy. Gestational, it is the carbohydrate intolerance of first onset or recognition during pregnancy, and sometimes it so happens that women who are already diabetic might be first diagnosed during pregnancy, and these also are included under the gestational diabetes mellitus. And whether insulin is used or not, or whether the diabetes persists after pregnancy or not, all these come under the gestational diabetes. Magnitude, as I said, about 17 to 20% of the population in the urban region, and India is supposed to be the diabetes capital, and Hyderabad is the national capital of diabetes. Indian women are 11 times more prone for gestational diabetes, and if the number of patients with diabetes is 8 crores the world over, about 2 crores of them are in India. Why is it important? Because 2 generations are affected, are at risk of developing diabetes in the future. And if you look at the diabetes complicating pregnancy, the complications which come are different in the pre-gestational diabetes from the gestational diabetes. If you look at the pathophysiology of diabetes, pregnancy is a diabetogenic state, because early gestation, the insulin requirement is very less, and the fetus acts as a glucose sink, and decreased substrate is available due to nausea and vomiting. Insulin sensitivity is increased, and there is enhanced maternal secretion. Then in second and third trimester, there is increased insulin resistance, and this is because of the presence of the hormones like human placental lactation, estrogen and progesterone. Apart from that, placental insulinases are secreted, which cause the destruction of the insulin, and there is increased lipolysis and alteration in the gluconeogenesis. And the impact of maternal hyperglycemia on the morbidity, there is an increased number of abortions. This is especially so when we have women who are having pre-gestational diabetes. Then this thing can be hypoglycemia or diabetic ketoacidosis, so it might be a complication with uncontrolled diabetes, pregnancy-induced hypertension, then polyhydramnios because of the increased surface area of the placenta and increased urination due to the fetus, and also because of infections. The infections also form part of the maternal morbidity. And sometimes in pre-gestational diabetes, there is a worsening of the problems like neuropathy, retinopathy, nephropathy and cardiomyopathy. So that is why whenever a woman comes with a known diabetes and she is pregnant, that is pre-gestational diabetes, we see them along with ophthalmologist. We have an ophthalmologist and a renal consultation before along with looking for the complications which pregnancy causes for diabetes. Then what are the health risks for gestational diabetes? Gestational diabetes, in the fetus you might have a hyperinsulinemia, a macrosomia, because insulin acts as a growth factor, and there is macrosomia of the fetus. Because of the macrosomic fetus, there might be birth trauma, especially shoulder dystocia, cardiomyopathies, and sometimes due to some unexplained reason we have term stillbirths in mothers who are having uncontrolled gestational diabetes. With the newborn, you have respiratory distress syndrome, hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, hyperviscosity, hyperbilirubinemia, and cardiomyopathy. These can be explained by Pedersen's hypothesis, which we'll see later. Then adult or child with diabetes, child with a gestational diabetic mother having a child, the child might be prone for type 2 diabetes. Then metabolic syndrome also might be seen. Congenital malformations account for 6 to the incidence of congenital malformations is more in women who are having pre-gestational or overt diabetes, and these account for 50% of the total perinatal mortality. This is due to decreased metabolic control during the organogenesis. That is why we insist for these women who are overt diabetics to have a proper preconceptional advice, so that they can start their pregnancies when the hemoglobin A1C level is at its optimum. Then the major malformations which are seen are renal agencies, caudal congenital heart defects, neural tube defects, and so many other congenital malformations are there. But regarding the caudal dysgenesis or sacral agenesis syndrome, typically when you see it, you can say that the mother could have been an overt diabetic, caudal dysgenesis in the baby. Among the congenital malformations which are seen in the fetus, the spinal abnormalities can be ranging from meningomyelocele, myelocele, and cephalocele, etc. Then among the serious malformations, almost all the malformations, ASD, VSD, tetralogy of Fallot, all the malposition of the great vessels, all these can occur. Renal agencies or polycystic kidneys can occur. But caudal regression syndrome, when it is seen in a fetus, you can be very sure the mother is a gestational diabetic. Then coming to the these macrosomic fetuses are mostly seen in gestational diabetic mothers. This macrosomic, it's defined as baby more than 4 kgs or more than the 90th percentile at any gestational age. The weight of the baby, if it is more than the 90th, then you can call them as macrosomic babies. According to Pedersen's hypothesis, maternal hyperglycemia causes fetal hyperglycemia. Fetal hyperglycemia causes fetal hyperinsulinemia, and insulin acts as an anabolic stimulus, and this enhances the accretion of fat on the fat and bones in the muscle. According to Pedersen's hypothesis, maternal hyperglycemia, fetal pancreatic cell hyperplasia causing fetal hyperinsulinemia leading to macrosomia. Macrosomia, difficulty might be there with the shoulder dystocias might be there leading to traumatic vaginal delivery. Fetal hyperinsulinemia, organomegaly of the liver and heart, and because of fetal hyperinsulinemia, it acts as a erythropoietic agent which causes increased erythropoiesis. Naturally there will be neonatal polycythemia, and neonatal polycythemia might cause because of the destruction neonatal hyperbilirubinemia, and because of insulin you have decreased surfactant production leading to hyaline membrane disease. And again another maternal hyperacidemia might cause fetal hyperaminoacidemia. Most of the problems which you see in the neonate can be explained by this Pedersen's hypothesis. Then respiratory distress syndrome is 5 to 6 fold more among the more than seen in what is seen in non-diabetic mothers. Then the cause of this is because of the surfactant deficiency. Surfactant deficiency is because proliferation and maturation of type 2 pneumocytes which produce the surfactant and help in expansion of the alveolar spaces. These are mostly dependent on the insulin, and with there is no production of the surfactant in these babies. That's why more of respiratory distress is seen. Then polycythemia is because of, polycythemia might cause hyperviscosity of the pulmonary bed, and glucocorticoid by giving steroids in the later weeks, the enhancement of the production of surfactant will be increased. Polycythemia, incidence of polycythemia is proportional to the insulin levels. Then insulin causes the erythroid progenitor in the marrow to make more red cells, and it stimulates the levels of erythropoietin, and hypoxia again is an inducible factor. Then most of the diabetic mothers, when they carry till term, we are apprehensive that the mother may lose the baby. This is sudden IUFDs of stillbirths. As percentage of HbA1c increases, the amount of oxygen carried by HbA1c decreases. So the amount of oxygen, and this the avidity with which the oxygen is bound is also changed. So there is a shift to the right of the oxygen dissociation curve. Placental edema might be there, and this again can cause sudden IUDs, and oxygen supply is unable to keep pace with the demand, resulting in fetal hypoxemia. Then severe fetal hypoglycemia can cover. Then both hypoglycemia and hyperglycemia can cause the fetal death. Hyperglycemia might lead to lactic acidosis, but these are all only theories which might cause the sudden IUFD in women with diabetes who are uncontrolled, and these are seen mostly at term. Then screening strategy, we need to screen these women when they come with pregnancy. Definitely a screening strategy should be there, but according to American Diabetic Association, they have a selective screening depending on the risk factors. What are the risk? High risk group you screen at the earliest, but among the Indian population the risk is the highest. So at the first visit itself, it is better to screen them, the woman coming for the first antenatal checkup. Better to screen at that time, and in case it happens to be negative, again the next screening will be at 24 to 28 weeks, and again at 32 to 34 weeks. Women who are in the high risk group constitutes the risk factors are maternal age of more than 25 years. Then ethnicity, Indian ethnicity indicates that we are 11 times more susceptible for diabetes. Then pre-pregnancy weight more than 80 kgs or BMI more than 28 kgs per square meter, or significant weight gain in early adulthood or in between pregnancies, or excessive gestational weight gain, family history of diabetes in the first degree relative, previous history of macrosomia, previous history of any congenital malformation, previous history of any unexplained fetal loss, or previous history of polyhydramnias, or a history of a sudden IUD or fetal loss, and a history of polycystic, all women with polycystic ovarian syndrome, when they become pregnant, better to screen them in the first trimester itself, or women with metabolic syndrome. So all these constitute the high risk group, and Indians come in the high risk group. So better to screen for diabetes at the first visit itself. According to ACOG and NDDG, National Diabetes Data Group, and American College of Obstetrics and Gynecology, they have a two-step method for screening. Two-step method, OGCT followed by OGTT. OGCT is 50 grams of oral glucose, or otherwise called as OGCT, oral glucose challenge test. Without regard for the time and the time of the day or the last meal, 50 grams of glucose is given to the woman, and after 1 hour blood glucose sample is collected. If it is more than 140 milligrams per cent, then it is taken as positive, and the next step is undergone by the woman. The next step is called as a OGTT. This is OGCT, and next is OGTT. OGTT is done with 100 grams of glucose, and values are taken for 3 hours, that is first hour, second hour and third hour, and depending on the values, if it is more than 105 or 183, 165 and 145, the cutoff level for the 3 hours and the fasting more than 105, it is taken as positive, and these women are labeled as gestational diabetes. And for whom, that is regarding the American Society and the National Diabetes Data Group, American College of Obstetricians and the National Diabetes Data Group. Now coming to the DIPSI guidelines, which are followed widely in India, and these are the guidelines because DIPSI is Diabetes in Pregnancy Study Group of India for screening, and this is a one-step screening. Also the WHO guidelines and the IADPS, International Association for Diabetes in Pregnancy Study Group. All these have one-step screening because women usually do not come back for a second test. When we do an OGCD followed by an OGTT, it's difficult to get the woman again for a second test. So it's better to do a one-step screening, and for India it is the most relevant one to do a one-step screening. So whom do we do? And we do a universal screening because we with the high number of diabetics in the society, better to do a universal screening. And when is it done? Earliest possible, and it is a one-step method. Earliest possible is when the woman comes for the first time. So fasting here in DIPSI guidelines, irrespective of the fasting status of the woman, 75 grams of glucose is given in 150 ml of water, and the test is done. And 2 hours later the sample is taken. If the sample is more than 140 milligrams %, it is taken as positive and the woman is treated like a gestational diabetic. So DIPSI method is 75 grams of glucose is given irrespective of the fasting state of the woman, and 140 is the cutoff level after 2 hours. Now coming to the other diagnostic values for the criteria. Carpenter and Kustan National Diabetes Group, they have 95, it's slightly more. So 95, 105, 1 hour, 180, 155 and 140, 105, 190, 165 and 145 are the National Diabetes Data Group. And WHO levels are fasting. Any woman with a fasting level of 110 and 2 hour level of 140 is taken as 2 hours after the glucose test is done. It is 140, it is taken as positive. IADPSD 92 and 153. Whereas in DIPSI, you do only one level, and that is after 2 hours of administration of 75 grams of glucose, and that is the cutoff level for DIPSI is 140 milligrams %. Now coming to the management of gestational diabetes, it is a team approach. No one either an obstetrician alone or nutritionist alone cannot do it. It's a team approach. So definitely we require the help of the dietitian and the obstetrician when we give advice to a pregnant woman with diabetes. So recommended target goal should be fasting should always be up to 90. First hour postprandial less than 140. Second hour postprandial should be less than 120. And 2 to 6 a.m. should be between 60 to 90 milligrams per dl. And HbA1c we strive to keep it at less than 6%. And ideal mean blood glucose level should be around 105 milligrams per deciliter. This is because if the blood glucose levels are less than 100, the perinatal mortality is around 4%, and if they cross 150 milligrams per deciliter, it is around 24%. So patient education, antenatal care first is metabolic control, and then the fetal evaluation, delivery, labor, and whether it's a vaginal delivery or an LSCS, postpartum care and follow. Patient education, you need to tell about the implications of gestational diabetes to the mother and her baby, diet and exercise review, self-monitoring of blood glucose, self-administration of insulin, and identification and treatment of complications. Diet and medical nutrition therapy. This is the first approach. Whenever a woman comes with elevated blood glucose after a screening test, that is if it is more than 140, we first go with the medical nutrition therapy, otherwise known as MNT. The goal is to provide adequate nutrition to the mother and fetus and to avoid excess weight gain. And we recommend 3 meals and 3 snacks per day, low glycemic food. A nutritionist should explain to the mother what is to be eaten, what is the caloric value of the foods she routinely consumes. Bedtime snack is a must to avoid late night hypoglycemia and early morning starvation ketoacidosis. So distribution will be proteins 20%, fat 30 to 40%, carbohydrates 40 to 50%, and breakfast will be 10% of the total calories, lunch should be 20 to 30%, dinner 30 to 40%, and snacks should be around 30%. The requirement depends on the basal metabolic BMI index of the woman. Then depending on that, for a normal person 30 kilocalories per kg per day. Overweight patient it is only 25, and underweight patient 35, and if it is an very obese patient, it goes between 15 to 20 kilocalories per day. Then you have to monitor the blood glucose, and the target should be kept between fasting should be less than 90, and postprandial should be 2 hours postprandial should be less than 120. These are all the foods to be avoided. Then recommended foods are small breakfast with high fiber food, and these are the foods which are recommended to be eaten. And mostly it is salads and cereals and grains. Exercise is compulsory. This is regarding the medical nutrition therapy. Along with the nutrition, half an hour of exercise in the morning and half an hour in the evening. It can be either a walking or a stationary cycling or yoga or low impact aerobics. Exercise, it should be done 1 to 3 hours after food, and it facilitates the glucose utilization and increased insulin sensitivity. Oral hypoglycemic drugs. Earlier there was a thing that they won't use. When do we go for this? When with your medical nutrition therapy, if you are able to maintain your postprandial values at less than 120, and your once a patient is on medical nutrition therapy, every 3 days we check the fasting and the postprandial values. Fasting less than 90 and postprandial not more than 120, we can ask her to continue. This is done over a 2-week period, and during 2 weeks, in suppose the three times out of 4, the values are more than 90 for fasting and more than 120 postprandial, then it is recommended that they need to have some other drug therapy apart from the exercise and the dietary advice. So the role of oral hypoglycemic drugs, usually it is started with metformin. Metformin, PCOs who are already on metformin can continue with that. It's a category B drug, and usually most of the oral hypoglycemic drugs are not recommended. Glyburide, this is the difference between metformin and glyburide. Then insulin. Most of the times with medical nutrition therapy, it is your blood sugars are controlled, and in some cases, if the blood sugars are not controlled, or women already over diabetics who are already on insulin, insulin has to be given. When to start, if it is not controlled with that in 1 to 2 weeks, and fasting blood sugar is more than 120, then you have to start with insulin. Which insulin is human insulin is the least immunogenic, and there are insulin analogs like Lispro and Aspart. So types of insulin: rapid acting insulin, short acting, intermediate acting, and rapid acting can be given to cover the immediate post-meal hyperglycemia, whereas intermediate acting and the NPH insulins covered for, because the duration of action is nearly 18 to 24 hours, they are given for the long time, usually at bedtime. Then monitoring should be intensive. Usually in the hospital we start them on a preprandial 3 times, that is pre-breakfast, pre-lunch and pre-dinner, and postprandial also post-breakfast and midnight value. So total you have 7 values per day. Then monitored for 3 to 4 days to achieve the target values. The dose calculation, first trimester the requirement will be around 0.6 units per kg, second trimester 0.7 units per kg, and third trimester about the requirement of insulin increases as the pregnancy advances. Then we start with 3 to 4 units of regular insulin 30 minutes before the patient has breakfast, and fast the patient can self-adjust by 2 unit increments. Usually we increase only by 2 units, and it can be increased up to 8 units per day for every 2 days. Dose time, most of the dose is given, 2/3 of the dose constituted by regular insulin, and 2/3 of the dose is given in the morning, out of which 1/3 is regular insulin and NPH insulin is 2/3. And 1/3 of the dose is given in the evening, out of which regular insulin is half and NPH insulin also is half. Then Somyoghi's phenomena and Dawn's phenomena, high night dose of insulin. So nocturnal hypoglycemia will be there. So between 1 and 5 a.m. if the blood sugars are seen, they appear very less. So, but immediately the counter-regulatory response will be there, leading to fasting hyperglycemia. So what we do is, in Somyoghi, you have to decrease the dose of long-acting or intermediate-acting which is given at the supper or bedtime. In dawn phenomena, there is no nocturnal hypoglycemia, but there is fasting hyperglycemia. If there is nocturnal hypoglycemia, which is counteracted by hyperglycemia, it is Somyoghi, and no nocturnal hypoglycemia, only fasting hyperglycemia, that is Dawn's phenomena. So increase the dose with long-acting insulin at bedtime. Then, diabetic ketoacidosis is a dreaded complication during pregnancy. We diagnose it by the ketone bodies, blood for ketone bodies and electrolytes, and we have to put them on insulin and maintenance. Fluids. A lot of IV fluids are given by continuous infusion along with insulin. Total replacement in the first 12 hours should be 4 to 6 liters of fluids, and then potassium correction should be there, and bicarbonate also based on the EBG it is corrected. Now coming to this, so far we have been talking about the managing the diabetes in the mother. Now coming to the fetal evaluation, it is at 8 to 10 weeks establish accurate dates with ultrasonography, so that the dates will not be missed, because the tendency for macrosomia might be there if the woman is not properly controlled. By 18 to 20 weeks, an ultrasound for fetal anomalies, a TIFA scan is done along with the fetal 2D echo, because at 24 weeks, because these babies are more prone for congenital cardiac abnormalities. From 28 weeks, ultrasound for fetal growth and liquor, and fetal surveillance tests like NST, biophysical profile, Doppler umbilical artery blood flow, to be seen depending on the situation. And these women are monitored very closely every 2 weeks for their blood sugars. And towards, in the late second trimester itself, they come for weekly monitoring. Then when to deliver, because of the risk of sudden IUD in the third trimester, and because incidence of stillbirths is more in the third trimester, women who are with the gestational diabetes and well controlled on MNT or oral can be taken till 40 weeks, but women who are on insulin can be induced at 38 weeks. GDM and on diet well controlled 40 weeks, on insulin 38 weeks, pre-existing diabetes 37 completed weeks, or overt diabetes 37 completing weeks, we have to monitor and deliver them. Then intrapartum care during labor, insulin protocol for labor induction or elective LSCS, target blood glucose should be around 70 to 100 milligram before induction of labor or for vaginal delivery or LSCS. Give the usual bedtime NPH dose, withhold the morning dose of insulin, and start normal saline. Once labor starts, if the blood glucose is less than 70, start 5% dextrose. Only when the blood glucose is less than 70. But if the blood glucose is more, monitor the hourly blood glucose levels, and depending on the blood glucose, you will start insulin. Then this is the low dose during the intrapartum period. If the blood glucose is 100 to 140, we give 1 unit per hour of insulin, rapid insulin, then connected with the 5% dextrose or ringalactate, and depending on this is called as a sliding scale. If it is more than 220, only 2.5 units per 25 ml per hour is given as this thing in normal saline. Postpartum care, you have to adjust the insulin dose depending on the requirement. Breastfeeding can be given, it is not to be avoided, and usually most of the gestational diabetics, once the delivery occurs, the insulin requirement also decreases, and the fasting and the postprandial levels only after 24 to 48 hours they come back as normal. Then these women have to be advised some contraception. Contraception is usually by using low dose low dose mini pills, or these women are advised barrier contraception, either a copper T or intrauterine copper T, or they can be advised condoms. Then follow up, repeat OGTT is compulsory, has to be done after 6 weeks, 6 months and yearly for gestational diabetes, because to prevent these women who are gestational diabetics, they have within the next 20 years there is a chance of developing diabetes. That's why they have to be monitored carefully, and to prevent future diabetes mellitus, you advise them to keep lean and fit. Breastfeeding, blood glucose level may be erratic in lactating women, so most likely hypoglycemia might occur within 1 hour after breastfeeding. Then oral hypoglycemic agent should not be started till the baby is, as long as the baby is breastfeeding. Yeah. Future risk of fertility for a diabetic mother are risk of recurrence of GDM 50% in the next pregnancy, increased risk of future diabetes, then in 20 years it is 50%. For the baby, childhood obesity, then impaired glucose tolerance and increased future type 2 diabetes mellitus. Contraception, all contraceptives can be used as in a non-diabetic one. Barrier methods are safe. Copper and levodopa are just safe and effective. Estrogen, progesterone pills usually not recommended, because progesterone increases the glucose intolerance, and estrogen, you have the thromboembolic phenomenon. So DIPSI has proposed practice guidelines for GDM in Indian environment. Universal screening ideal for Indian population. One-step approach for diagnosis, 75 grams, and after 2 hours if it is more than 140. Aim is to maintain euglycemia less than 90 and less than 120 milligram per cent. Intensive monitoring diet and insulin is the cornerstone of GDM management. Use of oral hypoglycemic agents and insulin analogs are still controversial, except metformin, which is being routinely given. Regular follow-up of patients with GDM is a must to prevent future diabetes mellitus. Thank you. A team approach is essential.